فحضرات الزملاء المشاركين راح نبدي بالسيمبوزيوم of refractive presentations, and I'm glad to ask Assistant Professor Najah القريشي to give us his talk about incisional correction of corneal astigmatism during phacoemulsification.
Yeah, good evening, everyone. My topic is incisional correction of corneal astigmatism after phacoemulsification. This is a work team done by all these persons with me. It is a cooperation between Ain Shams University and Baghdad Medical College. As we know that preoperative corneal astigmatism has been reported in about 50% of patients before phacoemulsification, and cataract surgery or phacoemulsification regarded now as a type of refractive surgery, so our aim is to eliminate all astigmatism, whatever the astigmatism is low. Many methods used to correct astigmatism, like a clear corneal incision and opposite clear corneal incision, releasing corneal incision, limbal releasing incision, astigmatic keratectomy, and nowadays toric IOL, in addition to photorefractive surgery. In this talk, we are using the clear corneal incision as a control and opposite clear corneal astigmatism for comparison. Just by routine phacoemulsification, we can do our incision on the steepest meridian of the cornea, and usually by our incision we can correct from 0.75 to 1 diopter of astigmatism, but by manipulation, the width of the incision, for example, from this shape to this shape, we can increase the effect of our incision, and also by change the shape. For example, this incision, which is parallel to the limbus, you can change more astigmatism, more than straight, and straight more than front incision. And also by the architecture of our incision. For example, this is here is biplanar incision. I mean two-step incision correcting astigmatism more than uniplanar astigmatism. The other method is to do an opposite clear corneal incision, which is 180 degree to first or phaco incision, and it is 1.5 millimeter from the limbus. So this is the initial incision for phacoemulsification, and we can do another incision 100 degree to the first incision to minimize astigmatism from 1 diopter into 2 diopters, 1 to 2 diopters. The aim of this study is to evaluate the efficacy and safety on corneal astigmatism with or without opposite clear corneal incision. This is a prospective, randomized, interventional, comparative case control study, including 40 eyes of 40 patients, 1 eye from each patient. We divided our sample into 2 groups, one for control, for phaco incision, and the other 20 patients with 2 incisions one the usual one and the other one is the opposite incision. We include in this study all patients with astigmatism from 0.75 into 2 diopter, and we exclude any patient who already having any previous intraocular disease or patients with complicated phaco procedure. Regarding the preoperative evaluation of our patient in this sample, it is a usual evaluation, and we add just corneal topography because the aim of this study is to eliminate the corneal astigmatism, not lenticular or retinal astigmatism. And this instrument is used just before anesthesia to avoid cyclotorsion of anesthesia, which is called White House gravity axis marker, this one, in sitting position before surgery. Coaxial small incision cataract surgery was performed on the steepest meridian by 2.8 millimeter microkeratome. And if we want to do another opposite clear corneal, this is the usual incision for phaco, and this is the opposite incision. Post-operative, also the usual evaluation, except we add another corneal topography to assess how effect our procedure affecting corneal astigmatism. We are, during analysis of our result, we depending on many factors, including target-induced astigmatism. And we mean by target-induced astigmatism is the intended astigmatism, which is usually equal to the preoperative astigmatism. And also surgical induced astigmatism. As you know, any incision can induce or can add a harmful effect to our result. Then the ratio between surgical induced astigmatism and the target induced astigmatism is called correction index. And the ideal for correction index should be 1. I mean the surgical induced astigmatism is equal to the target induced astigmatism. If it is more, it means there is overcorrection, more than 1. If it is less than 1, it means undercorrection. The other, which is not appear here, is the magnitude of error, which is arithmetic difference between surgically induced astigmatism and target-induced astigmatism. The result regarding the age, there is no difference between both groups. The age is the same. Regarding all other parameters, preoperative visual acuity, best corrected, topographic astigmatism, and corneal curvature, all is the same in both groups. And you can see that the astigmatism in both of them, initially before surgery, the mean is 1.37. It decreased to 1.1 in control group, and it decreased more to 0.7 in opposite corneal direction. This is the mean change of topographic astigmatism, and you can see here that the change is more in opposite corneal clear incision, which is about 0.6 or 0.7 comparison with 0.3 in usual, 0.2, and here is 0.6. Initially, we started with nearly both or equal degree of astigmatism for both of those two groups. This is a surgically induced astigmatism, definitely because here we have two incisions So it changed the curvature of the cornea by about 0.8 diopter, while here by about 0.4 diopter only. The magnitude of error, which is the difference between surgically induced astigmatism and the target, is more with control group and less, significantly less in the two incisions. And correction index is a very high in occipital. It can correct up to 0.6, while here between 0.2 and 0.3. We compare our result for many other studies, and our study goes with many other studies and maybe less or more effect of astigmatism. And all these differences are related to the incisional, to the shape, to the architecture of incision, and also for sample size and the follow-up period. And our conclusion that if you have any patients with astigmatism more than 1 diopter up to 2 diopters, you can do another incision on the opposite direction to eliminate any corneal astigmatism. Thank you for your listening. Thank you, sir.
Okay. Now our next speaker is Dr. Ammar Isa. Let's have a smile. Would you like to come to the podium, please?
بس تسد هذا. Sir, yeah, I have very short video, 3 seconds maybe, 4 seconds, just. Yeah, بس إذا تسد اطلع منها بس. تعال عمار. بس اطلع منها هي بصفها. بس سد هذا تلاقي فيديو ولا؟ يس هذا اللي جوا بس هذا اللي جوا شغله. So just I want to show this video because there is no any additional effort, there is no any additional step. Oh. So there is no need to change your policy or your way of surgery. Just when you inject the IOL, then at the end of the surgery, these are the 2 markers. This is one, and this is here the second one. At the end of the surgery, you can add another incision here. And because this patient having astigmatism, which is 2 diopter, so you can see we enlarging the size of the incision more than 2.8 millimeter. Thank you very much.